If I see a patient and hear in her story that she may have endometriosis, I'll say, you might have endometriosis, and she'll say, what's that? A lot of people haven't even heard of it. But what endometriosis is the inside lining of the womb, the endometrium, in another spot. So you've asked the causes, or it's often asked, what are the causes? We think it's probably mostly genetic. In other words, if your mother or grandmother or sisters have endometriosis, you are much more likely to have endometriosis. It's maybe not quite that simple. There are immune factors involved as well. And I think it's also important that people know not just about endometriosis, but its cousin or sister called adenomyosis, which is endometriosis in the muscle of the womb. Well, the best test is a good history. The best test of endometriosis is to listen to the patient. Did she take time off school? Did she take time off work? Did she curl up in a ball? Did she vomit? Did she go pale? Did she go sweaty? Do her friends say you look terrible at period time? Is she not going out socially? So listen to the patient. If painful intercourse, if any of that happens, or if any of that is in the story, then the only way to diagnose is to see it. Right? In the old days, that was to do a formal cut in the tummy, a laparotomy, but it's now a laparoscopy. So it really must be seen laparoscopically. And then the next bit is to cut it out, like surgically remove it or skin off the abnormal skin or peritoneum, send that to pathology, and then you get the visual diagnosis through the laparoscope and the pathological diagnosis with the histology. There are various ways that endometriosis can affect fertility. First of all, the quality of the egg can be affected. Secondly, the movement of the egg and embryo down the fallopian tube. But probably most importantly, or just as important now, is the spiral arteries, which are small arteries that protrude, if you like, into the muscle or are at the junction of the endometrium and the uterine muscle. And that's where the baby is going to get its nourishment from. And we know that people with severe endometriosis and proven adenomyosis do have decreased fertility, and we think that it's because those blood vessels, those spiral arteries, are narrowed, significantly narrowed. So these patients with adenomyosis, endometriosis, have decreased chance of getting pregnant, increased miscarriage rate, and then even after that, increased premature birth rates. So there's a fairly strong relationship there. I think people with endometriosis need to be treated for two reasons. One is that so their initial quality of life can be improved, right? So if someone's taking time off work or having pain or needing to take strong painkillers or really avoiding social contact because they just feel so miserable, it's important to treat that. Similarly, if they've got pain with intercourse and we can cut the endometriosis out of the other end of the top of the vagina, they'll get improved symptoms. But that also then helps fertility as well. So if we remove the endometriosis, and even more importantly, if there's endometriosis in big lumps, right? So that's deep infiltrating endometriosis. Those people get a definite improvement in their fertility. Then, if there's additional adenomyosis, in other words, if there's endometriosis and adenomyosis, what we try and do is reverse the changes in those small blood vessels on the inside of the womb by giving them one of a couple of different hormones that basically switch off estrogen production for 2 or 3 months. And those drugs are Zoladex or Synarel for 2 months. And that improves fertility by dilating those blood vessels.